Guys, this is Erin Espinoza, one of the HEMOC fellows. Can you guys hear me okay? Okay. Um, so again, I'm Erin, one of the HEMOC fellows here at UC and the VA. Thanks for having me. Today we're going to talk about the bleeding patient. I'm sorry I don't have a more fancy title for this, but what we're going to do is kind of walk through a case. Okay, sorry, still figuring out the technical issues with this. So really kind of broad learning objectives. We're first just going to walk through even just how to work up a patient with a suspected bleeding disorder, and then how to manage an acute bleeding episodes in patients with hemophilia A and B, as well as von Willebrand disease. So first case, this is a 72-year-old male with a history of CLL, so it's chronic leukemia. He received chemoimmunotherapy back in 2012, and he came in with right thigh swelling and pain. So, right thigh swelling and pain can obviously be something very broad, but to me, if I was seeing this patient, I would first honestly ask him just to show me where he was having this thigh swelling and pain. And based on what I saw, I would start asking him questions. So this is what you see. He pulls back the bed sheet and his gown, and he's got this very large hematoma on the posterior region of his buttocks, going down his thigh and even down into the upper region of his calf. You can see that there's more darkness here. It's more tender and kind of firm here. He's having difficulty laying it down because it's so painful. So questions that you should be kind of not just asking yourself, but the patient, obviously. This gets into what we call the bleeding history. So first, how long does bleeding occur after minor injuries? Hopefully you're asking him, even just minor injuries back when you were a kid, a teenager, young adult. Have you ever had extraneous bleeding? Does the bleeding occur ever spontaneously, such as with epistaxis or even just like minor gum injury, maybe when he's brushing his teeth? What's the size of the bruise? Are they just dime-sized bruises that he gets after hitting his thigh on the side of a table? Or are they really large hematomas that we just saw? Does he get bleeding after surgeries? Specifically, this comes with like tooth extractions. A lot of patients will get a tooth extraction, maybe a wisdom tooth as a young adult, and they'll wake up in the middle of the night and have blood essentially pooling onto their pillowcase. That's not normal. So that should be prompting you to be thinking there might be an underlying bleeding disorder. For women, you want to think of excessive hemorrhage after childbirth. How many tampons or pads do they use on their heaviest days of their periods? And then how severe can their iron deficiency be with menorrhagia? Medication-wise, is the patient on blood thinners, of course, but also remember that NSAIDs and fish oil, they can cause platelet dysfunction, which can make them more prone to bleeding. Alcohol use is important, as well as cirrhosis, which can cause portal hypertension, splenomegaly, splenic sequestration, thrombocytopenia, kind of all following in that order. And so that should prompt you to be thinking about the bleeding patient as well. And then, of course, family history, so hemophilia von Willebrand's disease. Yes, both of these can be inherited. Von Willebrand's disease has a kind of variable penetrance, so to speak. And there are cases of hemophilia that are not acquired, but are actually, they don't get inherited like the usual X-linked recessive type. So this patient says, no, he's never had issues with bleeding in the past, spontaneous or with his wisdom tooth extractions, until about 2 months ago. He got a Mohs procedure actually 2 months ago with this basal cell carcinoma on his cheek, and he had post-op hematoma. That actually required electrocautery. but he still has some oozing from the site and has to keep a bandage over it. He denies any trauma to the right thigh where the hematoma is. He's on a baby aspirin, which was held 5 days before the Mohs surgery, and he has not restarted it. Again, he's got this large, not just bruise, but hematoma on his right thigh that's hard, tender, and he denies any other like mucocutaneous bleeds like epistaxis. So differentials. The way I think about differentials maybe is a little bit different from other people, but I think what are the few things that are going to kill the patient quickly and that I cannot miss. So for a bleeding patient, a few more acute ones come to mind. As a hemonc doctor, I'm always worried about missing acute leukemia. And this should be one that you guys are thinking in your heads too, especially because acute promyelocytic leukemias, those are the ones that have the blasts have the hour rods. That'll be a board question on somebody's exam, I'm sure. But those patients can get DIC, and they can even just present as DIC. But of course, we see DIC in sepsis, pancreatitis, and pregnancies. So DIC is another differential. And then, of course, the one that you guys love to consult hemonc on, and we don't mind it at all, but TTP and less commonly HUS. What about all the others? So ITP, but of course the platelets should be fairly low, somewhere around like 5 to 10,000 even. They might have more petechiae and less likely to have like these hematomas. HHT, so that's the Alzer-Weber-Rendu syndrome. Those patients are going to have telangiectasias on their tongue and their lips, even AV malformations in the lungs and the brain. They're prone to bleeding. Really any kind of vitamin deficiency, but especially vitamin K. And then of course, hemophilia A and B, excuse me, those patients are usually going to have some kind of family history. They will know their own bleeding history very well. And then of course, von Willebrand's disease, which we'll get into later. And then there's the acquired factor deficiencies. So what labs do you want first? Of course, the ER has already given you a basic renal panel and CBC. So a few things should, kind of scream out to you. Obviously, the white cell count is 42, but remember this is a guy with CLL, and that's about his baseline. But he's got a hemoglobin of 7.7. His baseline, say, is 12 to 14. And he's got a new AKI, so his creatinine's up to 2.19. His baseline is about, we'll say, 1. For the anemia, you want to focus on the MCV. His is actually normal, maybe on the more higher limit of normal. So even if they're bleeding, they might not show a microcytic anemia, especially if it's more acute. The reticulocyte count is technically a normal value, but is probably hyperproliferative for his degree of anemia. And then in terms of the differential, his lymphocytes are more predominant in the white count, and that's unchanged from his baseline. And thank goodness the counter did not show any blasts. So you're thinking anemia plus AKI, maybe I need to be thinking about TTP. Sometimes a smear can take longer than just adding on an LDH and haptoglobin. So you check those, and those are normal. You're worried about DIC. Fibrinogen is normal. Normal fibrinogen is usually okay, but for DIC in like a really, really sick patient, that's usually not normal, but this guy's kind of mediocre sick, we'll say. Peripheral smear finally comes back, and it's got just an increased number of lymphocytes, maybe some smudge cells, no schistocytes, normal RBCs, and the platelet size and number are normal. So the one thing that you're really missing is the coags, and that I left out towards the end because I want you to be thinking, hopefully that's the one thing you really need. So you see that the PT is normal, the PTT is high. The upper limit of normal for PTT is about 30 or 35. So that's definitely outside the range of normal. So hopefully your next question you're asking is, okay, well, the anemia is, obviously due to this probably large hematoma, maybe some other blood loss. The AKI could maybe be explained by the anemia itself, dehydration, etc. But what about this prolonged, just very isolated? What are the causes of that? First, of course, is one of the easier ones, heparin. But he's just coming in and he's never seen heparin pretty much ever in his life. DOACs can also cause very mild elevations, but not to that extent. Lupus anticoagulant, this should be in your differential if the patient comes in with actually thrombosis. So arterial or venous thrombosis. But remember, this guy's bleeding. He's not clotting. And then we have factor deficiencies. So these are factors 8, 9, 10, 8, 9, 11, and 12. And we'll get into why those specifically we need to think about for PTT. And these can be inherited or acquired. And then, of course, von Willebrand disease. Sometimes you'll see prolonged PTT, but that can be variable in these patients. So we talked about those factor deficiencies, and that means that we have to think about the coagulation cascade. I'm really sorry that this looks more complicated than it is, and hopefully I'm not losing you yet, but I'm going to break it down to you pretty simply, and then we'll kind of go into the details. So ignore everything, and let's just focus on the fact that there are two pathways, the intrinsic and extrinsic pathway. Both of their goals are to get to factor 10A. So factor 10A is the first part of what we call the common pathway, and then that activates prothrombin to become thrombin, and factor 5 there helps out with it. And then thrombin helps out to convert fibrinogen to fibrin, and then you have your clot. That is the simplest explanation of the clotting cascade that I can give you. Now, to look at it in more detail in terms of those factor deficiencies that cause a prolonged PTT, I mentioned factor 12, factor 11, factor 9, and factor 8. And lo and behold, as you can see, those are all part of the intrinsic pathway, which is how the PTT is eventually measured. So next steps, you've ruled out heparin use, and the patient's bleeding, he's not clotting, so he doesn't have a lupus anticoagulant that you're aware of. What about these factor deficiencies or maybe von Willebrand's? So the next step is the mixing study. This would be for any patient, whether it's just an isolated PTT or let's say it was an isolated PT. Your next step should be the mixing study. So a mixing study is, this is where you mix the patient's blood with normal blood and see what happens to the clotting time, whether it's the PT or the PTT that you're interested in. So for example, let's say the patient is deficient in factors, and the factors here in this diagram are blue. If the patient is missing factors and you mix it with normal blood, then the clotting time eventually should go normal or at least near normal. However, if you have an inhibitor present, and that's essentially an antibody that attaches to and binds that factor, and you mix it with normal blood, that inhibitor is just going to keep kind of eating up all those factors, and the clotting time will not correct. So in this guy, his PTT was, again, severely prolonged. It was up to 88. And when they corrected it, it went down to 41. Now the reference range, the upper limit of normal is 35, but this is a really big correction. So yes, it doesn't complete all the way, but it's such a huge correction that we kind of more or less count it as a correction. So next steps are to order those factor levels, the 12, 11, 9, and 8. And you find that factor 8 is essentially undetectable. Now, some would argue to check a Bethesda titer, which is essentially measuring the amount of a potential inhibitor. So this guy over here, measuring the amount of a potential inhibitor that could be present. And I think they did that in him because, again, it corrected kind of close to where we wanted, but maybe not to the extent we were hoping for. And so there is a mild inhibitor present, but probably not the effect of causing any clinical significance. So what are the conclusions from this? So you have an elderly male with a subacute bleeding history, a large spontaneous hematoma with an isolated prolonged PTT that corrects on a mixing study, and a severely low factor VIII level. You have an acquired factor VIII deficiency. So what does that even mean and how do we treat it? So these are autoantibodies that attack the factor VIII. Half of the cases are going to be idiopathic and the other half are going to be from autoimmune causes, pregnancy, and even cancer. So for him, we're thinking that the CLL was causing some actually autoimmune issue that was attacking his factor VIII. Most patients are going to be elderly males like this guy, and most patients are going to have more hematomas as opposed to hemarthroses, those bleeding in the joints that you would see more commonly with like a true hemophilia A or B patient. The bleeds are going to be spontaneous, be retroperitoneal, less so you'll see GI and GU and intracranial bleeds, but that's not as common, but it is possible. Treatment is it's pretty easy, just replace the factor VIII. And the way you know that you're replacing it is enough is you check the factor VIII levels. And usually the goal with these patients is more than 80%. If you're worried about an underlying autoimmune disorder, you can give prednisone 1 mg per kg. This guy, because he had underlying CLL, I think they gave him just a one-time dose of rituximab, which is a monoclonal antibody to CD20, which is a receptor on the B cells, and that kind of helped calm down the CLL. So, what if you actually had that inhibitor present? So remember that would be where you have a high Bethesda titer. What you really need is what we call a bypassing agent. And there's two broad types. There's activated PCC, and that's really the easiest to come by in any hospital. The brand name is FIBA, and that stands for factor VIII inhibitor bypassing agent, and it contains factors 10, 9, 7, and 2. And remember, those are your vitamin K dependent factors. The other way to bypass the inhibitor is to give him recombinant factor 7A, and that might seem counterintuitive. You're giving factor 7 to an inhibitor of factor VIII, but what you're really doing is bypassing the entire intrinsic pathway and activating the extrinsic pathway.
Question.
Oh, we have a question. What is the difference between an autoantibody against factor VIII and an inhibitor? So that's a good question. My understanding is that, for example, in this patient, the autoantibody to the factor VIII for this guy was essentially destroying the factor VIII. So you couldn't even detect it in the blood, as opposed to the inhibitors are attaching to and kind of almost clearing out the factor VIII. So the factor VIII in an inhibitor, it's still there. There's factor VIII still present, but you can't detect it because the antibody is attached to the factor VIII. Hopefully that makes sense. Good question though. So really quickly, I'm going to just kind of briefly comment on hemophilia and von Willebrand's disease because you will see these types of patients on the hemonc ward service. So hemophilia, remember, is an X-linked recessive disorder, and it's a deficiency either in factor VIII, hemophilia A, or factor IX, which is hemophilia B. 10 to 20% of female carriers can actually phenotypically have hemophilia. And the reason being is because of lionization, which can inactivate the more or less normal X chromosome. And so they only have the X chromosome that has the hemophilia disease. Classification is based on the factor level. So mild is between 5 and 49%. These patients are really just going to bleed with any trauma or surgery, Moderate is between 1 and 5%. They can have some spontaneous bleeds, but then our severe hemophiliacs have very low, less than 1% levels of factor 8 or 9, and they will more frequently bleed spontaneously, and they usually require some kind of prophylaxis medication that they take at home. Von Willebrand's disease, on the other hand, remember that von Willebrand's disease, when there's any kind of endothelial damage, it's released from the endothelium and kind of unravels itself. It's a huge molecule and it binds to platelets, which are here in purple, and that's kind of the other start of the primary hemostasis for clotting. Von Willebrand's disease is the most common inherited disorder. It's about 1% prevalence. There's three main types of von Willebrand's disease, and I won't even try to make you understand them because they're even confusing for us hemonc fellows. But more or less, one is mild, two is a little bit worse, and three is very severe. So for any hemophilia von Willebrand patient, this is whether you're working in the ER, in urgent care, getting sign out from the ER, or maybe seeing one of these patients who might have a bleed in your clinic. The first thing to do is triage these patients very quickly and get their bleeding history, especially adults. These guys should really know their history already. And when they tell you they think they're bleeding, believe it. We really do not treat based on any imaging showing us there's a bleed or even an abnormal exam. We treat just based on the suspicion of a bleed. And the other rule is to follow that what we call factor first. That means give the factor replacement. Everything else, imaging, any kind of procedure you're wanting to do, needs to come second. And then, of course, don't hesitate to call us, pharmacy, who will be giving the medication because it is very expensive. And then, of course, your best phlebotomist that you can find to avoid multiple sticks that can cause more hematomas. So bleeding in these patients, again, factor first. For hemophilia A, you give factor 8. And the best way to think about this is for every 1 unit per kg of the factor 8, it increases the level by 2%. For hemophilia B, it's essentially a 1-to-1 conversion. So in very broad terms, we kind of think about their bleeding history in terms, or presentation in terms of major bleeds, kind of moderate bleeds like hemarthroses, and minor bleeds, which can be mucocutaneous. And you can see that the goal factor level we reach goes up with the more severe bleeds. We give more frequent dosing and higher dosing the more severe bleeds, and we keep them in the hospital longer for that treatment the more severe the bleed. Hemarthroses are going to be the most common bleeding events for hemophilia you will see. They might just have like a tingling sensation. Remember, factor replacement is, the first thing you really need to do, but you can also treat them with rest, ice compression, and elevation. Please, 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 whatever you do not give these patients NSAIDs unless, hemonc essentially approves it, because that can cause them to bleed further due to platelet dysfunction. Intramuscular bleeds are less common, but can be deadly, and that's because of compartment syndrome. Specifically, an iliopsoas hemorrhages can be very deadly because they hide. They can create a lot of blood loss that you might miss early on, and these patients have to be treated in the hospital for weeks with serial labs and imaging. Complications from this are going to be like a hip flexion contracture and even femoral nerve paresthesias. In the von Willebrand patients, these are going to have more like mucocutaneous bleeds, so gum bleeds, epistaxis, maybe GI, GU bleeds. 3 broad categories of treatment is desmopressin, but these patients, to even give it, they have to have a documented response. So don't just be giving desmopressin to a von Willebrand patient unless you find in their chart that they have a documented response. Antifibrinolytics are nice for like a tooth extraction. You can kind of wash around gently in the mouth, tranexamic acid. And then, of course, just like hemophilia, they have their own replacement therapies. So there's 2 broad types, plasma type, plasma-derived, and then recombinant. At UC, we have Hum-AP, which you might be more familiar with. You do have to be careful because these don't only have the von Willebrand factor, they also have factor 8. And if you give them too much, where their factor 8 levels go even greater than 200%, frequently, you are putting them at risk for thrombosis. So just kind of in conclusion, the bleeding patient requires a multidisciplinary approach. You know, hematology and pharmacy especially are here to help you. So just some take-home points. Remember that the right questions can help in your diagnosis. Understand, hopefully, the very, very basics of the coagulation cascade, because they can help you work up the bleeding patient and interpret lab values. The mixing study is one of the big things I wanted you to take away. So remember that if it corrects, it's a factor deficiency, you need to check the factor levels. Then you just easily treat with factor replacement. If it doesn't correct, there's likely an inhibitor present and you need to order the Bethesda titer. That you need to treat with a bypassing agent like APCC or factor 7A. And then remember, for hemophilia and von Willebrand disease, these patients who bleed, factor first is really the main thing I want you guys to take away. So thank you. I think we have another question. Why do you only correct the factors by 50% in a minor bleed? Why would you not aim for 100%? Is it due to cost? Is there a downside to completely replacing their factors in a minor bleed? Oh, that's a really great question. So I actually took out one of my slides that kind of explained that a little bit. So the best way to understand that is for patients, especially if we're talking about hemophilia patients, you know, let's say you have a severe hemophiliac whose factor 8 level is less than 1%, and they are on a home regimen of factor replacement, not because they're bleeding, just for prophylaxis. Your goal is to put them into a mild or moderate state. You do not care about getting to 100%. We're not trying to make them, you know, quote unquote normal, like somebody who does not have a bleeding disorder. Really, we're just trying to improve their quality of life, avoid hospitalization, avoid the spontaneous bleeds. So same with the patients who are having an acute bleed. The minor bleeds, if you just get them to 50%, the factor 8 works really well. We don't really need 100%. Hopefully that answered your question. So the last thing I will just say, I did give you guys some homework. And oh, hold on. Can you answer Gordon's question? Oh.
Imaging indicated for suspected hemophilia.
Oh, okay. So Gordon asked, hey Gordon, is imaging indicated for suspected hemarthrosis in a known hemophilia patient? No, I cannot emphasize that enough. No, it's really not indicated. And I know you guys aren't usually the ones ordering it. It's, you know, these patients present to the ER usually. Usually the ER gets like an X-ray, but you know, based on all of the studies and even the people over at Children's who treat hemophilia patients a lot more, you know, the general guidelines is these patients really do not need any imaging. You could maybe argue if you're worried about like, you know, the joint bleed extending down into the fascia and you're worried about compartment syndrome, sure, of course, get some imaging. But remember that imaging comes second and your factor replacement has to come first. Hey, Danny, so does the same go for intramuscular bleeds or, okay, yeah. So that's what I'm saying, Danny. So intramuscular bleeds, if you're worried about that or any kind of abdominal pain in a hemophiliac, sure, of course, get the imaging, but remember, give them factor first. Any kind of concern that you have for a hemophiliac who comes in, especially to the ER, just give the factor first and then get your imaging second, especially for those intramuscular or, you know, like ileoPSOAS concerns. Of course, you need imaging for that. Matt, so for suspected moderate hemarthrosis, how often should we ideally be checking factor levels? Does it depend on the level of how bad their hemophilia is? Yes. So Matt, I'll actually come back to this slide, which I breezed through really quickly. So for, moderate hemarthroses, again, we're not reaching that factor level of 100%. Um, we're dosing the factor replacement about every 8 to 12 hours, and that's how often we check the factor levels. Um, you know, for a hemarthrosis, again, it kind of depends on how severe the hemarthrosis. If it's more on the severe side, you can give the factor replacement every 8 hours and check the levels with that, or you can do every 12. And some patients, they might even be able to be treated as outpatient. So it would even be hard to even check their factor levels. You are welcome, Matt. So I'll still stick around for more questions, but the next slides I won't go through. I can send out the PowerPoint to you guys so that you have it, but I have about, I don't know, maybe 10 slides left over that kind of walks through, what are the causes of like a prolonged PT, and how do you think about any kind of coagulopathy in a liver disease, DIC patient, or vitamin K deficiency. Because I know we as hemonc fellows, we get that question a lot from you guys. Any kind of coagulopathy, and it can be difficult to tease out even for us fellows. But hopefully the PowerPoints help you walk through how to treat it, how to think about it. Christina said, "Great talk. Bring on the Mathis test." All right, guys. Well, thank you again for having me. Send me an email if you have any questions. Again, I'll send out the PowerPoint. And yeah, hope you all take care. Have a good weekend. Stay safe.